Right. So the outline of my topic will be why PAP therapy, what are the benefits, rationale of use it in sleep disorder breathing, what are the indication where we should use PAP and what kind of PAP, how to initiate this therapy, and how to follow up these patients. Are there any side effect complication or adherence issue that I'll be talking about. So the first thing is the spectrum of sleep disorder breathing. It is widened and improving. So as in the last lecture we have seen that URS has been out. So spectrum varies from mild to severe OSA versus simple snoring to controversial entity now UARS, hypopneas, obstructive sleep apnea, and obesity hyperventilation syndrome. We all had some flavor of this in different lectures, so I'll be just compiling what to treat and how to treat. So this is what we are trying to treat at different levels, whether it is the neuromuscular level, whether it is the endocrinal level, whether it is the neurological level. And all of this is basically creating one problem, that is the daytime symptoms in these patients and the nighttime problems that most of the time patient is not aware of. And daytime symptoms, most of us are taking it as a part of routine of our overwork. Very, very subtle symptoms, early morning headaches, daytime sleepiness, poor concentration, irritability, falling asleep during sleep. But if we will not treat sleep apnea, what will happen? So we are prone to develop all these diseases: hypertension, stroke, heart failure, coronary artery disease, cardiac rhythm problems, type 2 diabetes, GERD, nocturnal angina, hypothyroidism, and neurocognitive difficulties. If you find people are having this disease, then these are generally poorly controlled. Right? And there are increased mortality associated with this, which can indirectly be correlated to your sleep apnea patient or sleep disorder breathing patients. They have 10 times more likely chances of accident. So it is not the disease of a person, rather it is a community hazard that we are treating and that we try to see. So whom should we treat? All the sleep apnea patients, all the sleep disorder patients, how do we treat? So these are the four major factors which we should consider while we are planning treatment for our patients with PAP therapy. Severity of sleep apnea, which has many ifs and buts that we were discussing. Extent of arterial oxygen desaturation if we are treating overlap syndromes. Presence of or absence of symptom in these patients despite it is mild, moderate, severe on your sleep study. Whether these symptoms are leading to increased risk of cardiovascular mortality and morbidity in patients, and impact of OSA on the sleep partner, which is probably the most ignored part when we are treating sleep, sleep apnea, but it has been in the guidelines. If the bed partner is also getting problem because of sleep apnea, you need to treat the person. Right. So how does it work? Very, very basic phenomena that, that is still there and it stood the time-tested therapy is creating a airway splint. So while we are treating the other modalities, we are treating the other part of this sleep apnea syndrome, neuromuscular junction, neurological, loop gains and all these things. The therapy which is still valid and probably the gold standard till now is making a airway splint in this upper airway so that all these events can be abolished. So this is called pneumatic splint, and it also increases lung volumes in some patients to some extent, and that may increase upper airway size, stiffness of upper airway and making them less collapsible. So that is what the basic therapy when we were talking about sleep apnea. What are the treatment objectives? What we want to achieve with this therapy? We want to reduce the daytime symptoms of the patients, improve the overall quality and decrease the long-term cardiovascular consequences in terms of morbidity and mortality, and overall improvement in the well-being of the patient. So what are the treatment options? We have medical management. We have devices in terms of positive airway pressure, that the main, main talk here, and the orodental appliances and surgical option we have. PAP is the treatment of choice in most of the moderate to severe OSA patient, and in mild OSA patient, there are some ifs and buts, but when we talk about, considering PAP therapy to our patients, we have AHI on one axis and symptoms on other axis. So it is very, very clear that if your patient has moderate to severe OSA, you need to treat these patients with PAP therapy. But if it is mild and you have significant symptoms, then also it warrants treatment in your patient, but the compliance or the acceptance rate is very, very less in the patient who are suffering from mild OSA. So should mild OSA be treated in such scenario? So the first thing that my last speaker was also telling, that when you have mild OSA, it doesn't mean that truly patient has mild OSA. Go by these 2-hour sleep, or you repeat the sleep study, or go by the daytime symptoms of these patients. Many a times we see that these patients truly have moderate to severe OSA. That's why they are coming to you, because they have some trouble in the day and they have some trouble in the night. So this was the study, Wisconsin study again. 28% of the individual with an AHI greater than 5 but less than 15 has subjective sleepiness score of more than 11. And they have twice higher chances of incidence of hypertension in these patients. Snoring alone can cause carotid atherosclerosis. So this is also a risk factor even if you are not seeing AHI in your patient. So mild OSA could also have adverse consequences, but it has been seen that there was no benefit of CPAP treatment in a group of non-sleepy patients. So if your patient has daytime symptoms, then probably this will work better and your patient will accept it better. So that is the thing. Weight loss, when we see the patient who has mild OSA, our first reflex is, rather than going for CPAP, let's go to weight reduction in these patients. But weight reduction is a time-taking process. So if the patient is symptomatic and wants to lose weight, consider this as a second option and try and encourage your patient to use CPAP in such scenario, because it has long-term consequences to your patient. And this is the most important part. Rather than prescribing PAP therapy to your patient, you need to counsel your patient first. You need to explain the report to your patient, that what is happening to you in the night, what are the long-term consequences of this, why it is happening, and what are the treatment options, pros and cons, whether you are talking about surgical therapies, oral appliances, or PAP therapy in these patients. And drowsy driving counseling is very, very important. In US, it has to be documented on the paper. If the patient has sleep apnea and patient drive, then there are higher chances of accident in these patients. Evaluation of other associated comorbidities is again very, very important when you talk about restless leg syndrome, associated depression, insomnia, insufficient sleep, chronic pain, and narcolepsy. If you treat these symptoms, the adherence and the acceptance of the treatment is very well in these patients. So how do you go about this? So you need to understand the level of, understanding of your patient, the factors that are likely making them away from accepting CPAP in terms of fear, social stigmas, the kind of fear they have that it is an addicting therapy. So process of introducing PAP therapy should be very, very time-consuming process. You need to, counsel your patient, make them aware, keep them in confidence that this is going to help you out. Thorough, careful communication, providing all answer to your patient's question is very, very important. You need to give them a touch and feel of the device, that this will not harm you. This will not create any problem while you are sleeping. Instructed that how to breathe in the interface. Once the patient applies this CPAP or PAP therapy, there is a gush of air. So patients sometimes get feared after it. So pressure should not be applied till the time this interface is properly connected to your patients. It should be turned off before getting it out. So this decreases anxiety in your patient. And patient must be told about the sensation of the pressure in the back of the throat and lung. Some intentional leak that is acceptable. So all these things you need to counsel your patient before prescribing PAP therapy, that no, you have sleep disorder breathing and you need to take this. This will not work anyways. So what about moderate sleep apnea? PAP therapy is the treatment of choice as far as the moderate sleep apnea is concerned. Vis-a-vis oral appliances that I'll be talking very briefly has 50% efficacy. And when we talk about surgical therapies in these patients, it has only 30% effectiveness. So this is very, very important to make your patient understand that the other therapies are not as good as your PAP therapies, and it might even after applying those therapy, you have residual disease. So this data is published in meta-analysis, and results have also shown that surgery is inferior as far as the treatment of moderate OSA is concerned, until unless there is a basic defect in the upper airways. Severe OSA, beyond any doubt, it is the treatment of choice for most of your patients. And number of RCTs, meta-analysis, systemic reviews has been done, which showed that it gives you overall improvement in terms of quality of life, daytime symptoms, long-term complication preventions. So this is the therapy that is must for all sleep apnea patients. And how to choose your PAP devices. So when you go into the market and see that even the workshop has these there are multiple types of devices, starting from continuous PAP therapies to bi-level PAP therapy, which is BPAP, or the brand name is BiPAP. Then you have different modes in BiPAP, that is S spontaneous, ST spontaneous and time triggered, and time triggered. Then you have auto titrating devices, or auto CPAP and auto BiPAP. Then you have AVAPs or VT BiPAPs, which is average volume assured pressure support. So how do you go about this? This is again very, very important. So when we talk about providing PAP therapy to our patient, we need to be as accurate as possible. So as accurate, I always give this example to my patient, that if your specs number is right, then your acceptance is better. If it is even higher or lower, it will not work as we want for your patient. So choosing an effective pressure, the most important thing is you should do a good polysomnographic titration of your patient within standard approach, right? And what are the goals of these titration? The goals of titration is that there has to be elimination of all apneas, all hypopneas, and all respiratory effort-related arousals, which is little controversial, but it is the standard protocol, and if possible, all the snoring also. So if you can eliminate all these things by carefully titrating your patient with a PAP device, probably the acceptance is best. So there are guidelines which has been given by Sleep Association in terms of how to titrate your patient while you are applying CPAP. So you need to begin with 4 centimeter pressure and increase every 15 minutes till the time you abolish all the apneas, hypopneas, and reras. If there is any 2 obstruction, 3 hypopneas, 5 reras, or 3 minutes of snoring, you need to increase the pressure further. So this is how you titrate your patient. Once you achieve the goal, then you need to maintain at that particular pressure for minimum 30 minutes and see that there is no further events during that PhD titration, or if the REM sleep has also been included in this or not, and then you try to decrease the pressure a little bit and see if there is no further apnea. And that is how you titrate your patient, and this schematic diagram has been given in the guidelines that you can all go and see. So CPAP is the most basic device that we are talking about. It is a continuous positive airway pressure to make a pneumatic splint in the upper airway, and so it provides only a single set of pressure, and most of the patients, it is, mostly acceptable. If you are talking about moderate to severe sleep apnea patients, it provides a constant set of pressure during sleep. Many of the patient has positional sleep apnea that we were talking about. So if the positional sleep apnea is there, then probably auto CPAP is the best option. Why? Because it auto titrates itself as per the need of the patient, whether the patient has high requirement during the supine position, or the requirement goes little down during the lateral position. So it gives, so we set a window in this auto CPAP, and the pressure fluctuate in between as per the need of the patient. But it is not for everyone. So this is a common practice. As soon as we see that the patient has sleep apnea, we provide or we tell them to use auto CPAP with a window of 4 to 20, which is totally unacceptable. And auto CPAP has very limited use. When you have positional sleep apnea, probably it is the best choice. When the patient has recurrent upper airway obstruction in terms of nasal congestion, frequent nasal congestion, probably it has some use. And for the patients whom you have done a home sleep study, for the titration of these patients, you can apply this machine for a period of 7 days and see the mean pressure, what is there, and then you can set the pressure accordingly. So it is not for everyone. It will not work for all your sleep apnea patients. And there are limitations of sleep therapies also. So CPAP treatment is most of the time associated with suboptimal adherence. The most common reason is high pressure, difficulty in exhalation, and coexistent central apneas and or hypoventilation, which is being overlooked. So the patient does not feel comfortable or does not get full relief. That's why patient is uncompliant to this therapy. So newer devices and techniques and modalities has been incorporated into these machines to, to tackle these situations in these patients. One of this is a flex. What is flex? It basically drops the pressure during the time of exhalation, because continuous pressure is coming, so patient feel uncomfortable when they are exhaling. So it decreases the pressure further during the initial part of exhalation, and then later on it increases to the optimized pressure or the pressure that you have set. So this is one way of dealing this exhalation problem in your patients. It has different setting as per the need of the patient. And if the patient is still intolerant to your pressure, or during your polysomnographic titration of your patient, you feel that the pressure requirement is more than 15, then you split this pressure into IPAP and EPAP. After ruling out that there should be no oral or mask leak, there is no difficulty in exhalation, and air in the stomach can also sometimes create problem, and this is one of the reasons to split the pressure into two parts. So when you are splitting this pressure, so these are the indication of non-obstructive sleep disorder breathing where BiPAP is of use, like patient who has muscle weakness in terms of neuromuscular or chest wall diseases, obesity, hypoventilation syndrome, although the guideline says that you start with CPAP, but in India the scenario is that once the machine is being purchased, it cannot be returned or replaced. So most of the time, these patients are the candidate for BiPAP titration and BiPAP pressure. So non-invasive ventilation, if required in patient like we were listening to Tejas regarding overlap syndrome, then probably this is the right direction that you titrate these patients on BiPAP therapy. Patient who develop profound desaturation in REM sleep without a major increase in obstructive event, these are the patients for BiPAP therapies. So how do you titrate BiPAP? You just titrate, apneas, abolish all the apneas with your EPAP, that is the expiratory pressure, and you titrate your IPAP to an extent that all the hypopneas and RELA will be abolished. That is how you titrate. Otherwise, the schematic diagram is almost the same. I don't know whether it is visible from the back or not. And the maximum pressure that you can increase is up to 30. So do not change EPAP simultaneously and routinely. Once the apnea has been abolished, you need to increase the IPAP only over a regular period of time to see that all the events has been abolished. Then there are modes in terms of S mode. S mode is the very simple mode that the patient is able to cycle his or her breath spontaneously. So this is called spontaneous mode. So patient cycles the device from EPAP to IPAP.
How many slides, Rahul? How many slides?
Sorry?
How many slides are left?
2-3 more. So I'll just finish it fast. So if you need to add a backup in these patients, if you feel that the cycling pattern of your patient is not reliable in terms of central sleep apneas or neuromuscular disorders, then you add a backup rate. But if you want to take a full control of the patient's cycling, then you add time mode, that after every specific time, the machine will cycle from inspiratory to expiratory phase in your patient. So this is again a new mode, which is average volume assured pressure support, in which if the patient is very, very suffocating, not able to take or tolerate this pressure, then you give this pressure, and it is mainly helpful in patient who has obesity, hyperventilation syndrome, COPD patient, and restrictive lung diseases. So although this mode has been developed, but it has not to be shown to increase the adherence in almost all the patients. So you need to be very, very careful while selecting your patient that what is the problem and how to titrate and tackle this problem. So not all modes works for every patient. Behavioral modification has immense importance in terms of weight reduction, good sleep hygiene, sleep position therapy in some patient. Then this oxygen supplementation, nasal corticosteroid, avoidance of sedatives and alcohol. These things has to be titrated as per the need of the patients. Weight loss, although considered is, it has been considered that as soon as I lose my weight, I'll get rid of my OSA, but it is a very, very difficult task. So it has always given a second priority. If your patient has sleep apnea, moderate to severe, give the CPAP first and then ask for weight reduction in these patients. And there are hormonal changes in the body which creates a kind of insulin resistance and other resistance in the body that patient is not able to lose weight very easily unless this cycle of sleep apnea is being taken care of, right? So even after bariatric surgery, 1/3 of the patient has some kind of residual OSA which needs CPAP therapy in these patients. So it is again not a 100% cure for the patient if the patient is going for bariatric surgeries. The other important thing is compliance and complication. So we see that most of the patient gets immediate improvement even after applying this PAP therapy. Despite that, the acceptance rate is suboptimal and the non-adherence rate is to the tune of 50%. And there are many reasons to this. Difficult falling asleep with the mask, improper fit of the mask, nasal dryness, congestion because of the leakage, feeling of claustrophobia in some patients, especially females, facial skin abrasion if the patient is not properly taking, putting the mask, air leak, and conjunctivitis. So how do you improve this compliance? First and the foremost thing is counsel your patient better, tell them how to use this device, what are the benefits, what are the loss if they are not using this device. Optimal titration is absolutely must. Correct machine, you need to choose the machine as per the need of your patient. Trying various type of mask and nasal below, we have a good demonstration of all the kind of masks here. Humidification, if your patient feels more of dryness as a major problem in putting up this mask. Routine follow-up to encourage your patient and see whether the patient is compliant or not is again very, very important. And providing patient education and support program, because the initial compliance has to be maintained from the doctor side. So this is again very, very important. There are different sizes of the mask that you can choose from. These are some of the new therapies in terms of Provent. Very, very simple therapy that it has a inhalation port which are bigger and exhalation port which are smaller, so it create a kind of PEEP and create some kind of upper airway splinting, but again not very effective so far and very limited data on this. This mini micro PAP device is also available in the market, but because of the high pressure it keeps popping out from the nose, so it is again not very, very acceptable. I'll not talk about surgery, we have a full lecture on this, but there are surgical management for specifically selected patient and there are non-surgical management in terms of oral appliances. I'll stop here. If you have any question, I'll be very, very happy to answer.
Thank you, Rahul.